Well, tēnā koutou katoa. I'm really delighted to welcome all of you to the first department seminar for a very long time. And of course, we're great to have all of you here, but I know there's a lot more people online as we're just getting back into the habit of coming back into work. And we're delighted to have Professor Neil Pearce here today to talk to us. Neil will be known to most of us. He taught many people in New Zealand. I just checked, his face is actually on the wall there, one of the framed photos from 1990, when he was teaching epidemiology in this department, which of course was back in the hospital or the old medical school. Since then, he's gone on to set up a centre at Massey University and now is based at the London School of Hygiene and Tropical Medicine. He is an eminent global epidemiologist, interested in a vast array of areas, particularly NCDs, but he, as we'll hear today, he keeps his hand in many other areas. So we're really delighted to have him here today to talk about the UK experience with COVID-19. I must say that throughout that global crisis, we regularly had advice from Neil about what was happening in the UK. I have to say, rather than what was working, what was probably not working so well. But it was wonderful support, and I think also for epidemiologists in New Zealand, I think Neil's always been extremely generous with his time, helped out making connections, and giving really supportive advice. So it's wonderful to have him there. It's also wonderful to have him here today. And he's also travelling with his partner, Deborah Lawler, who's also an eminent epidemiologist based at Bristol. And she can also talk about wonderful subjects like Mendelian randomization. But we haven't got quite time to fit both in, so we've got Neil. Great. And we will take questions initially in the room and then online. Thanks.
So thanks very much for the opportunity. I've got too many slides, but I've resolved that by, I'm just going to talk about the first 4 sections, and the 2 sections at the end, I'll just save the slides in case anyone, but if you even hinted an interest in them in the questions, I'll bring them up. But I'll talk about some of the methodological issues of studying COVID, a bit of the history of the pandemic in the UK. The main bit is just studies we've done on risk factors, infections and mortality, and then some of the issues that arise from that. So this is where we were 3 years ago. This was all the data that we had. It was just case numbers. And that's okay for the start of an outbreak, but they weren't even adjusted for population and so on, and this was what was all in the media. So a group of us, me and Jan Vanderbroek, Tyler Vander Weel, Sandy Greenland, we did a piece for the American Journal of Public Health on how we actually need accurate statistics for some of the debates we were having. And just to flick through a few of the issues is population. And some of the population is infected. Some of them have symptoms, but other people have the same symptoms, but not because of COVID. Some of them get tested, and we have test positives, false positives, test negatives, and false negatives. So none of the squares line up. And then, of course, we have people who die. So the statistics are a mess. And they're partly a mess because we more or less can pick up the deaths. Even early on, almost all of those were being picked up. We'd find cases, but we knew it was a subset of the cases. We knew the population. The thing we really didn't know was the proportion of the population that was infected. And that was actually crucial for everything else. Because remember, at the time, we were arguing, what's the death rate? And what's the case fatality rate? Is it 1%? Is it 0.1%? And that was crucial in terms of the different national strategies. And no one actually knew because they didn't have population survey data on the proportion of the population that was infected. So, and a lot of countries have more or less given up doing surveys because you have global burden of disease, you have electronic health records and so on, and they've lost the capacity to do surveys. And the first thing you needed to do was start doing surveys. In the UK, they started a COVID infection survey. It's 150,000 participants. I'm one of them. I get tested every month. They give me a 20 to 25 pound voucher. It's paid for my new fridge and it's working on paying for my new washing machine. So it costs a lot, but it's a really valuable resource. And this illustrates the sort of problem with not having good population data. I won't go through this, but these are different estimates early on of the effects of the relative risk of people working in healthcare. And for Biobank, which was one of the first ones to be reported, they said that healthcare workers had 7.4 times the risk of COVID infection. Yet at the time, we knew that the mortality ratio was only about 1.1. And this was just because healthcare workers were getting tested and other people weren't getting tested. So there were big problems with the statistics. It just happened that the year before, Jan Vanderbroek and me had done some work and published a paper on the test negative design, which is used a lot for evaluating vaccine effectiveness, but can also be used for risk factors. And the idea is people get tested because they have symptoms. Maybe half of them have COVID and the other half have something else, but they've both gone through the same process in terms of seeking healthcare, wanting to get tested, having a car so you can drive somewhere and get tested, which was a problem in the UK. So the test negative design gets around a lot of those problems. And we just compare the test positive cases with the test negatives. It's been used a lot for vaccine effectiveness, which we've been doing, but we also started to look at risk factors. One more problem with the data that I'll mention now, basically, even from the beginning in the UK, the mortality data was pretty accurate. The test data for infections was only accurate from random population surveys. The non-random testing could be used if you did the test negative design. But the real problem was hospital admissions and ICU admissions. And this is from a paper that got widely publicised. There was a long interview on the Today Show, which is the equivalent of Morning Report. They said it was probably going to be published in The Lancet, but it wasn't. It's still never been published except on medRxiv. But what was widely reported in the UK was that South Asians were presenting at an average age of 12 years younger, and they were ending up in ICU more even though they were younger. And therefore there was a problem for South Asians. And of course people immediately think it's genetic. And I contacted the main author of this to explain why he'd got it wrong. And he said, well, let's see what the reviewers say. And they've never actually fixed it. So this is conditional on having been hospitalised. This is the risk of ending up in ICU, and you can see it's much higher for East Asian and South Asian. So they presented at a younger age, and they're more likely to end up in ICU. First bit's easy. The reason that the average South Asian patient is 12 years younger is that South Asians in general, on average, are 12 years younger than the rest of the population. And if you standardise for age, it disappears. The ICU thing's a bit more interesting, and this was circulated early on, and it was never officially adopted as policy, but it was unofficially used. And basically, it was a scoring system. And if you were, so it was mainly age, but then there were a bunch of comorbidities, and if you scored low, you were okay. But if you scored high, like if you're over 80 or if you were 50 or 60 with a comorbidity, you got enough points so you were lower priority for ICU. And so this is from the data from that actual paper. This is adjusting for ethnicity and comorbidities, that if you were over 80, you only had 0.16 the risk of getting admitted to ICU compared to a younger person with basically the same severity of disease. So basically, if you're old, they gave up on you. And the reason that, so South Asians were getting admitted to ICU more often because they were younger, and the old people were not being admitted. This was widely reported in a book by the Sunday Times team. I've just read a book called Sweden's Pandemic Experiment, and it documents that in some regions and some periods in Sweden, they took this further, so that if you were over 80 or over 60 with a comorbidity, not only did you not get into ICU, you didn't get into hospital. They kept you in the rest home and gave you only palliative care. Didn't get oxygen, the only thing you got was morphine. So, and it's very well documented that it happened at least some of the time in some regions of Sweden. Okay, so methodological issues. Mortality is easy. Infections from random surveys are good. Non-random testing, you need to use the test negative design. Hospital admissions and ICU are really hard to interpret. So the pandemic in the UK, I downloaded this figure on, I've got a version without the date on, but I'm pretty sure it was the 12th of March 2020. Downloaded it, put it on the wall. It was still there when I came back to the office a year and a half later. When I looked at it, I had two thoughts. And actually, this is, unfortunately, I'll put the wrong version of the figure in here, but I can summarise the version that I was referring to. At the time, the UK was down here, and Italy was up here. And you could do some very simple calculations that it was doubling every 3 days, and we were 12 days behind Italy. And two thoughts came to mind. One is we're stuffed. And the reason, not only could you see where we were going, but the same day the government issued a press statement saying it was doubling every 10 days, and we were 4 to 6 weeks behind Italy, so there was no need for panic. And that wasn't the government getting it wrong, it was SAGE, the main advisory committee. And the reason is they didn't believe the descriptive epidemiology, and they used a really sophisticated model, which produced results that were total rubbish. And in fact, 12 days later, sure enough, we were the same level as Italy, and we locked down. The second thought that occurred to me was New Zealand has time to avoid this. And I wrote a piece saying, please lock down now, at least to save some time. Don't make the same mistakes as the UK. And I tried lots of journalists, and I couldn't get a reply from anyone. And then after a couple of weeks, I saw that Michael and others had been saying this, more or less the same thing, and New Zealand had locked down in time. But so I've still got that piece that's unpublished. Okay. This is the UK pandemic. This is deaths. That is the beginning. Eventually they locked down. The middle of 2020, we actually had really low rates, and at that time we could have adopted an elimination strategy. A lot of us, a substantial minority, were arguing for it, but not successfully. We had Rishi Sunak's eat out to help COVID policy, so we've got a lot of cheap restaurant meals. It started to come up again. And it was one of the few times SAGE actually spoke separately from the government and said it's accelerating. But the government still decided, took advice from Tegnell in Sweden and a few other people, and decided not to do anything. They did have a temporary circuit breaker late in the year, and this is the Christmas, the Christmas wave. And we had, in November, December, we had Boris Johnson in Parliament accusing Keir Starmer as being the Grinch who wanted to kill Christmas, and saying we're going to save Christmas and it's important. And for that reason, in the end, they had to have a few measures, and early in January, they had to basically lock down then because it was out of control. But they kept things open for much longer than other parts in Europe. And this is one example where you can actually see the effect. This is the black line's the rest of Europe, and this is the UK. And if you count the area under the curve, there's about 20,000 deaths just from that one decision to keep things open for an extra week or so over Christmas. We spent more time locked down than New Zealand as a result. In terms of death rates, this is a bit old now, but you can see we're sort of fourth. New Zealand was fantastic, of course, but we were amongst the highest. Essentially, after US, Italy, Belgium, we were the highest Western countries. Spain was very high too. And if you look at the effects on the economy, this is New Zealand, small drop in growth, hardly any deaths, and this is the UK, much bigger fall in the economy. And we're the only economy in Europe that hasn't recovered to the level that it was before the pandemic. So, risk factors, infections and mortality. So we didn't do very well in terms of the pandemic. We did quite a lot of good research though. And there were these national core studies these were funded out of the office of the chief scientist, so they were not put through the regular system. And there was six sets of core studies, and we were involved in the one on transmission and environment, which was led by the Health and Safety Executive, which is the equivalent of the Department of Labour or WorkSafe. And then within that transmission theme, with transmission core studies, we were involved in two main things. Like there was people studying ethnotes, studying ventilation and so on, but we mostly did workplace outbreak investigations and then a bunch of studies, essentially using routinely available data. So it was those two themes that we were mostly involved in. The first one, we did 16 workplace outbreak investigations, and we added on a questionnaire and we used the test negative design. But unfortunately, for all of them, you just couldn't get into the workplace fast enough. And so we ended up with very few cases. So we have some nice descriptive studies just describing the workplace and what people think some of the factors are. But it was a bit disappointing. The theme 3, the research in key sectors, is the main thing I'm going to show. And particularly, we've done a bunch of studies involving readily available data sources and also data already collected by particular companies. So if you look at infections, we have the COVID infection survey, which I mentioned. There's Virus Watch, which is run by University College London, which has a slightly different study design, but it's more or less doing the same thing. And most of our studies of infections, we use those two sources, those two surveys. So we did a bunch of risk factor studies. Studies with COVID mortality as the outcome. We had, with ONS, the Office of National Statistics, we had mortality data. They were allowed to link it to the census, and the census was a bit old, but it's now been linked to the more recent census. We also did studies of excess mortality and some studies of proportional mortality using just death certificate data. So I won't show you all of these, but I'll show you a couple of key things. The first crucial paper that came out in March was a report from ONS, and that had huge death rates by occupation. And it wasn't just the healthcare workers and social care workers, there were things like bus drivers, taxi drivers and so on. And they had 3 or 4 times the risk. And in a couple of committees I was on at the time, I was saying, well, just be a little bit careful. We have to try and adjust these for region and ethnicity and so on. It won't change very much, but we need to do it before we can draw conclusions that there were something like 20 important occupations, all of which were greatly increased risk. So working with ONS, we could link the data to the census. And this was the model we worked with, that you have a particular job like being a bus driver and you get occupational exposure to COVID from passengers. But also, you do get it at home, and living conditions vary by occupation, because if you're in a poorly paid, insecure job, you can't afford to isolate. No one was being paid to isolate. You're living in cramped conditions, your kids are going out and socialising and so on. So it's work-related, but not in the sense that you're getting infected at work. So, and when we look at differences by occupation, it's the sum total of these two things. So we wanted to at least adjust for ethnicity, geography and so on, but also do some adjustment for living conditions just to see how much was going through this pathway and how much through the living conditions pathway. And I've never seen anything change so much in my life. So, for example, if you look at taxi drivers, the relative risk is 4.5. You simply adjust the region and ethnicity, it goes down to about 1.8. And you adjust for living conditions, it goes down to 1.5. And virtually all of them go away. There's nothing bigger than 1.5. And it doesn't mean that this is not important, but the people on the whole are not catching it at work. It's the consequence of work in terms of their living conditions. But almost everything ended up in the region of between 1 and 2, and most commonly about 1.5. And of course, you have the suspicion that if you had better confounded data, it would have gone away completely. So the only things that didn't change much were actually healthcare and social care, because they're more middle-class occupations, and therefore the adjustment for living conditions didn't make so much difference. This is excess mortality. This is the first wave, the second wave. Lately, well, there is still a bit of an excess overall nationally, but this is working age people. And the first wave, healthcare was the highest, and it's actually underestimated because there was a move to refer any deaths from a healthcare worker from COVID to the coroner. And in England and Wales, if it's referred to the coroner, it doesn't get counted until the coroner is finished, which takes a year or two. So there's a couple hundred deaths in healthcare workers that were missing from these statistics. The second wave, the healthcare workers were doing pretty well. You can see the orange here. And in fact, being a frontline healthcare worker became one of the safest jobs to have in the UK because they had proper protection. But social care was very big in the second wave. This was the saving Christmas wave. And what was really depressing about it was really grim. It was winter, the ambulances were stacked up outside the hospital, and at that stage we knew we had a vaccine that worked. We only had to hang on for a couple of months and you could have protected most people. But we didn't. And so you had this huge second wave, which particularly affected social care. This is healthcare workers broken down for the first wave, and doctors were very high, and then quickly settled down. To some extent, though the numbers are small, the medical support staff stayed high. And I suspect what happened is that they finally sorted out the PPE and so on for the frontline staff, but not for the rest of the people in the hospital. So they were still getting infected. We did some stuff on vaccination. I won't show you the details, but this is one of the more interesting slides. This is ability to work from home and vaccination rates. So of course the people like us who can work from home also got vaccinated more. But it also indicated that by that time, telling people to work from home may not have been particularly useful because those who could work from home were mostly already vaccinated. One analysis we haven't done, but I'm very keen to do, is one of the highest vaccination rates was in doctors and one of the lowest vaccination rates was in alternative healthcare people. And so comparing the infection and death rates in the two groups is something we still want to do. These are from the ONS infection survey, and this is four different time periods. And you can see that healthcare workers were elevated initially. And by the third and fourth period, which is basically March 2021, this is first wave, second wave, and then this is the two subsequent sort of periods when you didn't really have a wave. But you can see the risk in healthcare workers came down a lot. Education was much lower because the schools were closed. And then they came up once the schools opened. Other essential workers were actually not particularly elevated, but for reasons we don't fully understand, they were elevated in the second and third time period. We also got a bunch of experts who developed a job exposure matrix. So there was a US survey which had a lot of good information, which was then adapted for the UK by a panel, and they defined 8 characteristics of work: number of workers at the website, nature of contacts, risk of contaminated work surfaces, working indoors or outdoors, can you socially distance, need and usage of face covering, and the last 2 were job insecurity and proportion of migrant workers, because we thought those would indicate workplaces where maybe the working conditions were not so good. But basically, these had no effect, to our surprise, but the first 6 did. And if you take these first 6, and I won't go into the categories, but if you simply order them from least risky to most risky, you can see whether you use the National COVID Infection Survey or virus watch, you get more or less the same answers, that you get reasonably consistent increased risk, for example, with increasing numbers of workers and more or less for the nature of the work, contaminated surfaces, inability to social distance and so on. So that's across the whole pandemic, but if you take the infection survey and look at, well, in fact, if you take both and look at particular periods, the increased risks were entirely in the first period. And in periods 2 and 3, there was no increased risk. So we still don't understand that, but basically, we did learn a few things, and the workplace did get cleaned up to some extent, and there was a lot more PPE, and for some period, there was a lot more wearing of masks and so on. So conclusions of those studies, we get reasonably consistent results from the different study designs. The one exception is that mortality data I showed at the beginning, but then if you adjust it for living conditions, you get more or less the same answers, you know. There are occupational differences, but they're partly explained by living conditions rather than working conditions. The occupational differences got smaller as the pandemic went on. The healthcare sector was affected with higher infection mortality early, but not later. The education sector actually consistently had high infection rates, but overall not increased mortality, which is something we don't understand. One thing that's been suggested is that teachers have probably had lots of infections already, and maybe some of those set up your immune system in a way. Don't know. And vaccination coverage and workplace factors predict the infection risk, and actually vaccination explains very little of the difference in occupational differences in mortality, but some of the workplace setup factors do. So, a few issues. I was worried I had too many slides, but I'm in danger of finishing early, but let's see how they go. So, some issues quickly. One is that we're trying to look at the long-term effects of infection in England, Wales, Scotland, Brazil. Need for surveillance, test negative design versus target trial emulation, and well, I'll go through each of these in turn, but the long-term effects of infection are just, they're important and we're studying them. The need for surveillance, I think, is really important, and it's kind of sad that a lot of countries now think that with electronic health records and global burden of disease, you can just do everything electronically, and it doesn't work very well for things that you can't pick up with EHRs, and doesn't work very well for pandemics. And I'll give you one example. We've organised the Isaac asthma study, which is now a global asthma network for about 33 years. And you have to do the surveys because, most asthma doesn't get picked up in a lot of countries. But I was on the GBD panel for respiratory, and basically we supplied the asthma data. We looked for lots of other stuff, but Isaac includes 100 countries. There was no other country that had anything available, so it was entirely Isaac data. In the first GBD report, they used that to estimate there were 343 million people in the world with asthma. But Bill Gates likes up-to-date statistics, so they have annual updates. From year to year, that number, 343 million, can go up 50 million or down 50 million, even though there's no new data. And it's because they have data on things like hospital admissions and mortality in Europe and North America, and they feed it into their Bayesian model and come up with a new prevalence estimate, which is just complete rubbish. So I think global burden of disease is good for the global burden, but it's totally hopeless in terms of looking at these short-term changes or differences between neighbouring countries, where one has data and one doesn't. So you need the ability to do surveys routinely, so then you can crank it up when you get a pandemic, and you can get in and do that initial population survey really quickly. Second thing, test negative design versus, have you heard of target trial emulation? It's something that the causal inference, people from Harvard are pushing. The idea is to design your observational study to make it look exactly like a randomised trial, like even matching exposed and non-exposed and so on. And they had a very nice paper in New England Journal, basically, which showed that Moderna does work better than Pfizer. And it seems pretty clear. And they did that by setting up a target trial emulation. But there you're comparing two groups which have both been vaccinated. And the confounding's not too bad. But if you're comparing vaccinated versus non-vaccinated, the confounding is just hopeless. And you can't get around it through any conventional way of adjusting for confounding. But you can get around it with the test negative design. So we've done half a dozen papers now in Brazil and Scotland, but this was the first one published in Nature Medicine using the test negative design. I've got a bunch of slides on vaccine effectiveness if anyone asks me, but the issue is more methodologically because a lot of people are pushing this target trial emulation design, and it works for some things but not for others. And things like the test negative design, triangulation, which Deborah has written a lot about, comparing different types of studies. You know, there's a lot of different things we need to do rather than just use the pure causal inference methods. All-cause mortality in New Zealand, you did pretty well. Virtually one of the few countries in the world to have negative excess mortality. I think it would be really important to find out what was lower, because as far as I can tell, it wasn't just from respiratory infections being lower. And some of the countries in Europe, for example, it looks like they also had lower non-COVID mortality. And it would be interesting to do comparisons of different countries and see if the same outcomes are lower in those countries that had big outbreaks compared to New Zealand, because it would be interesting. And hopefully it would tell us something about the effects of essentially restrictions. And this is the last slide. This was developed by some colleagues of mine very early on in the pandemic, and it was actually a guide for employers to say which of your employees are most at risk. And but it's quite interesting both scientifically but also in policy terms. The relation of COVID, the case fatality rate to age, is something really interesting and really unusual. And I did a paper on the relation to the multi-step model of disease, and it seems to fit it pretty well. But basically, leaving aside accidents, if you look at your risk of dying from any sort of NCD or anything, COVID basically multiplies that. So if you're sort of, in your 60s or something, your risk of dying from anything in the next year is about 1%. And if you get infected with COVID, your risk early on of having a case fatality was about 1%. If you're in the older age group where your annual risk of mortality is about 10%, your case fatality rate for COVID is about 10%. It multiplies, it's proportional. And there's no other virus we know of that does that. So there's something important scientifically. Friends I talked to at the London School tell me that the peak, your immune system is at its peak at about age 17 or 18, and then it's all slowly downhill. At every age group, women have better immune function than men, and there's good biological reasons for that. So man flu is a real thing. It's an unpopular finding, I know, but it's probably true. But then we have these other things that affect your COVID risk. So they say, take your current age, and of course they're starting with a man. And then they're saying, well, if you're a female, subtract 5. Ethnicity, I think that's rubbish, but their estimate at the time was to add a few years. BMI, you add extra time, and so on. And in policy terms, I think it's really important because age trumps everything. And I know people who have spent 2 years or more without hardly going out, and I know people in my department who have either retired early either because they have asthma or their spouse has asthma, and it's the equivalent of about 2 years of age. So the whole thing of comorbidities, with a couple of exceptions, has just been totally overblown. Because why on earth would you vaccinate a 30-year-old woman with a comorbidity and not vaccinate a 45-year-old man who has 10 times the case fatality rate, because age totally swamps these other things. And it's not something I've studied in any more detail. I think other people are coming up with schemes to integrate this data, but I quite like the idea of COVID age, and I think it's analogous to, like in the UK for cardiovascular risk, we use QRIS2. What's the thing you use here that integrates age and cholesterol and blood pressure?
Predict, I think.
Predict. So Rod Jackson and others, and that were involved. And the idea is you don't just take the test one at a time, you integrate. And this does the same. This integrates your risk. And just like you know, doctors should know their patient's predict score, they should know their COVID age. And ultimately you should make decisions based on COVID age, not by a whole bunch of, you know, things like we'll vaccinate the over 50s, and the under 50s with comorbidities, even if they have much lower risk. It would mean that for some age groups, you would vaccinate men and not women, which would be a policy thing. And no government in the world's done that as far as I know. But you might decide to do that or not do that and give the reason. But leaving the politics aside, but knowing your COVID age is by far the best predictor of your case fatality rate. And that's, I'll only run 5 minutes over time, I think. So I'll stop there. I've got plenty more slides if anyone wants to ask about them, but thanks very much for the opportunity to talk about this.
Yeah, thanks Neil. That was fascinating, and we've got some time for questions. I would say that in New Zealand, our ability to measure occupational status is very poor, and there's been very little work done that's analogous to what you've done. But are there some questions here?
Yeah, great stuff, Neil. Just exploring that issue around that potential for elimination that the UK may have had in August, September 2020. I mean, would they have needed a few weeks of continued lockdown to be sure about that, or would have probably had to require that sort of level of intervention, or do you think they were nearly there?
There was a lot of interest in it, and I arranged for Michael to give a talk at the school, and I think we had more than 250 people logged on, but it was still very much minority point of view, and I think that closing the borders was a really big thing, which most people weren't prepared to countenance, I think. And I think the bigger problem, and it wasn't just a UK problem, it was a European and North American problem, there was a certain, not an unwillingness to learn from this part of the world. It was almost like the thought never occurred to people that there might be something to be learned from what's doing here. So it's always just, you know, people wouldn't tolerate it. You know, Heathrow's busy, we couldn't possibly close the border. But then I didn't travel for nearly 2 years anyway, so it didn't really, and it was very difficult to travel, so it didn't really bother me if the border was closed. I think the rates got down to 1 case per million per day or something. You know, it was extremely low. It was as low as it was in New Zealand when you did the initial lockdown for a month or two. So it was possible. But the main thing is you would have had to have a plan. And you would have had to do the same things as here in terms of you would have had to close the border, you would have had to have a proper test and trace system. We spent 37 billion on test and trace run by companies like Deloitte's. Germany spent 2 billion doing the same thing, and it worked much better. And you would have needed to actually have a bit more social distancing when people had just already got very tired of it. So I think it was never seriously on the agenda. It was on the agenda just to have maximum suppression. So for a while, that was something that was an aim, but it was never seriously followed through.
So it's like the UK doesn't really believe it's an island.
No.
In some way senses.
Yeah, I used to have this constant thing, well, you know, New Zealand's an island. And I'd say, well, this is an island. And New Zealand's sparsely populated. And I'd say, well, you know, so are parts of the UK and there's places like Taiwan that are very densely populated, and Hong Kong for that matter, who were managing to do it. But yeah, I still don't quite understand why it was never considered seriously.
Thanks. I've got a comment and then a question. I think the part that Sweden took was a really interesting one, and I keep close contact with Johan Mackenbach and at Erasmus. And his view, he actually thought we should abandon older people too. He thought we were depriving young people. It's a very interesting retirement speech that he gives, and that we should concentrate on young people and not older people. He said the reason they didn't in Netherlands was because of that kind of the horror of what had happened in the Second World War and eugenics, and they'd been the parts of Netherlands that have been quite close to Germany, so they didn't want to do anything that discriminated against older people. Whereas Sweden was always a bit more equivocal about what its relationship was with Germany. So I don't think one can forget cultural and history factors in these things. Just to say, well, Tapicki's you're 70 or something, wouldn't pass muster in countries where there's whanaungatanga is a big deal. And then I was going to ask, so that was one. Do you want to make any comment on that?
Basically, no country managed to isolate the old people, and it's impossible. But suppose you put all the old people in rest homes and you had total security and so on. So none of them were infected, and you let the rest of the population get infected. You've only got to get one infection into the home and they're all susceptible, and it takes off. The idea that you could shelter the old people was always nonsense. You could give them a bit more protection, but unless you wanted to split up families and have people living in special camps, you were never going to be able to protect the old people in the way they claimed. It was just nonsense, and it was just done for political reasons, and mostly just who cares about the old people. Which, coming from New Zealand, I don't find a very good attitude.
The other question I was going to ask you about, I noticed on that occupational scale you had, there was surfaces, and a number of us, probably including you, were pointing out that it was ventilation rather than surfaces. And of course, was it measured in the end, ventilation in these places? So if you're a bus driver, someone's coming right up against close to you.
There have been very few studies of it. In our outbreak investigations, we did ask about ventilation, but the numbers are too small and the data's not very good. Kath Noakes and people did a lot of work on ventilation, but I'm not aware of any really good studies on ventilation and COVID risk. I know there's a lot of good studies just saying, here's the way you can improve your ventilation, but in terms of linking that to COVID risk, I don't know of any.
Because the work that Amanda, Michael, and I've done with the WHO, looks at crowding as the principal risk for infectious disease. So, you would think that was the way of transmission. Yeah.
Sorry, was there something else?
No, that was ventilation and the cultural.
Great, thanks.
And we've got some online questions here. Can you read those out, thanks?
Yeah, so first one from Richard. Thanks, Neil. You said that the mortality association with occupation largely fell away once living conditions were adjusted for, and yet you showed in the latest studies that at least in the first period there was an association of occupational risk with outcome. Can you comment on that? It seems contradictory.
Can you read the second half of the question again?
Sure. About this, in the latest studies, in the first period, there was an association of occupational risk with outcome.
Yeah, so there's still an association, but when we initially looked at mortality and we had these 3- or 4-fold risks of bus drivers and taxi drivers and so on, they seemed huge. And I think there was real concern that maybe we just have to close all these industries down. If you adjust for living conditions, it goes down to about 1.5 times. If you use things like the infection survey or the proportional mortality we did, the relative risks are about 1.5. So they're all still elevated, but they're just not elevated quite so much as we thought before adjusting for living conditions.
And then a second one from Jason. Thanks so much for the great presentation, engaging as always. I wonder if you have any comment on the impact of the pandemic on a potential cancer stage shift and any insights into how to best examine this methodologically. No, it's a really good question, but I have no idea. As you know, there's I'm not sure the situation here now, but there is some excess mortality in the UK.
And there's those who say it's because people weren't getting treatment, and there's others who say, well, some of it's long-term effects of COVID, particularly heart disease. And as far as I know, no one's really got on top of that. But yeah, it's not something I've kept up with.
Yeah. And I was just going to ask, where to from here? Because obviously we've got a new pathogen circulating.
Mm-hmm.
Last year in New Zealand it was the second leading cause of death. It will be less this year. It's still the burden of, the syndrome of long COVID is looking pretty awful. How do we manage this? Where do we set our settings in terms of infection control? And you could take a mitigation approach or more of a suppression approach. There's much discussion about this in the UK.
I think people mostly just want to think it's gone away. But we still have something like 30 or 40 deaths a day. And the UK is 13 times as big as New Zealand, but the peak was 1,500 deaths a day, so that's the equivalent of about 120 a day here. But it still goes up and down, but there's still 30 or 40, and it's sort of, I find it puzzling that people, find that acceptable. Obviously if there was 30 or 40 a day on the roads, we'd be doing something about it. I was kind of hoping New Zealand might show us the way to go, like they did early on. Now, I think unfortunately a lot of people have just given up. I don't think eliminating it is possible now, and I don't, both politically and practically. I still think we should do sensible things. We should have much better ventilation, which, things like ventilation in schools, there's still not very much being done about it. I think we should still encourage mask wearing in, like crowded public transport, though I must admit I don't do it most of the time now, but I know I should. I think we should still be doing sensible things, but exactly how you translate that into policy, I don't know. But yeah, it's a concern because it's not, it hasn't completely gone away, and it's and long COVID's a big concern.
Thanks. We'll just perhaps in one more question, if anyone's got any burning thoughts. Well, thank you so much, Neil. That was, very enlightening, inspirational. I think there's something there for the infectious disease people and the NCD people and those who are concerned about global health politics. So thank you very much, and also for being such a generous with your support for people in New Zealand and visitors to London, and keeping us up to date with what's happening over there. So thank you.
Great. Thanks.
Good.
Good. You can do. Yes, absolutely.
Yeah.